Good afternoon. My name is Deborah Levine, and I am the director of the Harlem Health Initiative for the City University Graduate School of Public Health and Health Policy. And we are so excited that you have joined us this afternoon. If you are sitting at your computer or you have the ability, we would ask that you please put your name in the cubicle so that we know who is here with us. And if you'd like to include your organization, that would be great. If you can't change your name, no problem at all. You're happy to use the chat function and put your name, email address in there so that we know who we're having a conversation with today. You will see we have a small survey that we like to start at the beginning of our webinar series. If you could just take a few minutes and tell us what's brought you here today so that we know, again, we're able to say who is participating with us. It helps our presenters have a better sense of who is coming and who they're talking to. And we know how to create that community circle. We still have a few more folks that are joining us. So it's just one question, and that is, what's brought you here today? You can choose all that apply. Are you a community member, an educator, a student, a community-based organization? Do you represent several of those organizations or parts of our community? Thank you, Priya. We'll get started so that we can respect people's time. Let's see. Here are our results. Looks like we have 57% of you are from community-based organizations. 29% are community members. 21% are community educators. We have several of our students, 29%, who have joined us, and we also have several faculty or teachers that are participating. So thank you very much for taking our survey, and we will share those results. So it gives me great pleasure today to bring my colleagues forward to have a conversation today about health equity and access to care. And their project working citywide. And so what I would ask you is to please give them all of your time, your energy, and your talents so that we can ensure that the focus groups and the work that we do on behalf of New York City's members, that we can give you the best quality possible. So what I will do is turn the floor over to Dr. Diane Romero, who will take us through and explain the project and tell you what our request is. So thank you very much, Diana. The floor is yours.
Well, thank you, Deborah. And I echo her sentiments, and I'm really very grateful for everyone who's taken time today to join us and to learn not only learn about this project, but also, more importantly, give us your ideas, share your ideas and your thoughts and your recommendations for how we can make it better and, roll it out across the city going forward. So I truly appreciate that you're here and really look forward to your insights once we've described what the project is about. So I, like Deborah said, I'm a faculty member here at the CUNY School of Public Health in our Department of Community Health and Social Sciences, and have been working for many years now on different projects that have been very community focused around New York City. I'll just give you a little snapshot. Quite some time ago, when St. Vincent's Hospital closed, I worked with a wide group of community leaders and members and stakeholders on a community health assessment or impact, if you will, of the closure of that hospital. And so it was, CBOs, health care providers, municipal leaders, etc. And so that was one project we did. And then a few years later, I worked with folks at Health and Hospitals on assessing the interest and impact of the options program, which was the precursor to what we now know as NYC Care project. And that involved 21 focus groups with community-based organizations across all 5 boroughs. Some of them took place in community settings with these organizations, and some took place at health and hospital locations and sites. And it involved a particular focus on individuals who were either using or eligible for that options program. So it had a strong immigrant focus, though not exclusive. And from that, the NYC Care program rolled out. So, just another example of some community engaged work that we've done with, large municipal entities in the city, as well as with very community-based and serving organizations. So that brings me to this project, which we got going this past fall, and we're continuing to roll it out. And it is a partnership with the Department of Health. So on that note, I'll move on. But as you can see, it has to do with health, equity, and access to care. And so I'll share more about that with you. Over. Okay. So what is the, HEAC project as we're referring it to? It is indeed a focus group project, and it is taking place across all 5 boroughs, or at least we're looking to engage New Yorkers across all 5 boroughs in this focus group project we're doing. Thus far, it has been virtual via Zoom, but we see ourselves moving fairly soon into in-person focus groups. And I'll talk more about that, but essentially starting out by Zoom, we knew might make the focus groups available to some people, but not to others. But in working with the health department, they really wanted things to start that way in light of what we've been dealing with in terms of COVID. But we see that evolving and being able to be actually present in different communities across the city. In any event, these focus groups are looking to specifically explore New Yorkers experiencing, accessing, or trying to access care at this point at New York City hospitals. And so whether it's in ERs or different clinics that are available through both private and public hospitals, it's any hospital in New York City, as well as maybe inpatient care. But it's that range of services that hospitals across the city provide that New Yorkers either have experience accessing that care, or maybe they try to, but they're not able to access care. We want to really learn about all of that. And some of the key factors that we're looking at as we do these focus groups have to do with individuals' racial or ethnic background, their health insurance status. At some point soon-ish, we'll be moving into, we don't care so much about citizenship, but might the experience with, being US born versus non-US born, I elucidate, different differences in accessing care. And then ideally moving into a focus on specific vulnerable groups. And again, I'll get to that shortly, but these are sort of the main factors that we're trying to highlight in terms of making sure that a wide range of diverse individuals are participating in these focus groups, so we can really try to see if and to what extent differences may exist in their experience accessing care. And in doing this, trying to be as broad-based across the city as possible, we've really been engaging in a wide range of outreach and recruitment activities. And I think the opportunities for outreach and recruitment are really infinite. And we've probably just scratched the surface on that. Clearly, this conversation we're having today is one of many, many attempts that we're doing to connect with stakeholders across the city and try to increase our outreach and recruitment. But as I said at the outset, to also get feedback and to see if and how we should be doing things differently or doing things better. And so we'll go into some detail about what we have been doing. In terms of who's involved in the project at this point, myself and my team, I have a colleague here, Samantha Weckesser, who's on this Zoom here, who's the coordinator of the project, and then there are several other folks here at the school who are part of this project team. As I mentioned, this is a project in collaboration and with funding from the New York City Department of Health and Mental Hygiene. And very specifically, and I think this is important, it's coming from the Bureau of Equitable Health Systems, which is located within the Center for Health Equity and Community Wellness. That center and that arm of the health department is really very, very strongly committed to trying to identify areas in need of attention with regard to health inequities and to try to collect data to inform recommendations for change. So they are really quite excited, about this project and feel that it fits solidly within their purview, if you will. One more thing I'll add to that is that when we started talking about this project a little over a year ago, they were very clear that the recent declaration that the New York City Health Department had made, basically declaring racism as a public health crisis, they felt that a project like this fit squarely within their desire to, try to address racism in public health and in healthcare, directly. And so that's sort of the perspective that they're coming from. But we're also seeking to be, partnering with and collaborating with community-based organizations, with different municipal entities. We've reached out to like the public libraries, for example, and the Department of Education, and others. And so that, like I said, this is an ongoing process. One thing, again, that we would really like your feedback on, so hopefully you're thinking about this as we go along, is, any additional groups, maybe your own, as well as other groups that you think, would be good to reach out to, so long as that they're in touch with the New Yorkers in some way and can help spread the word or possibly work with us. Okay. And, I'd like to say, if anyone has questions, please feel free to unmute yourself and ask a question. I know we're going to talk afterward, but I'm perfectly fine if you have a specific question, especially when I get into some of the details of the project. If you need clarification on something. But so the question is, why are we focusing on New Yorkers' access to healthcare? And so prior to the health department reaching out to us about this focus group project, they conducted an analysis of their own, which was, quantitative in nature. And it revealed pretty much what they expected, that there were significant differences in New Yorkers' use of hospital services. So they looked at hospital discharge data from New York State, and then specifically the hospitals here in the city. And they found these two, unfortunate but not surprising findings. It's sort of like the hypotheses that they went in with, because they were hearing a lot along these lines, that, that people of color, as well as those who either did not have health insurance or used public health insurance, were more likely to have been discharged, have been using public hospitals or safety net hospitals. and that people who identified as white and or had private health insurance, the opposite. They were more likely to have been using private hospitals in the city. These, immediately pointed to like significant differences in accessing healthcare along the lines of race, ethnicity, as well as along the lines of health insurance status. And the data that they used, as I mentioned, were from New York State Hospital discharge data from a data that is collected annually, New York Sparks data. So many on this call may be familiar with those data. Now, one thing about Sparks data is that we can do analyses like the ones I just described. It's very quantitative. They have information on patient characteristics like race, ethnicity, like health insurance status, income, etc., the services they receive, that kind of thing. So those quantitative analyses are very doable with data like Sparks data. And so what they did do was point to, yes, there are significant differences in the hospitals that individuals were accessing when we looked at racial ethnic identity and health insurance status. But they couldn't explain why, right? They couldn't explain what are the underlying factors, what are the experiences that people are having that are leading them to use certain, services from certain hospitals and not from others. And so I think to their credit, the folks in the health department really wanted to understand the why. And in doing so, that naturally brings us to a more qualitative type of project. And so that's, where they reached out to us, given some of our, previous experience doing similar kinds of work. And a focus group study seemed to be the way to try to include a relatively larger number of people and get their stories in like a conversational setting, which essentially, as we all know, is what focus groups strive to do, really create an opportunity, a safe space and a comfortable space for people to talk about their experiences. So in terms of how the project has been rolled out, and I want to emphasize rolled out. Oh, I see a question from Dr. Franklin.
Yes.
Please go ahead.
Can you go back to the last slide?
Sure.
So, and so basically on your second and third bullet points, I'm just looking at that and thinking about neighborhood adjacency and access, and so proximity to public health hospitals and the way they're clustered within around the boroughs. I don't know if you guys answered the question of these what's and the whys, but it certainly seems like that plays a role in whether someone accesses public or private hospital, and also the perceptions of welcome, being welcomed or unwelcomed, or perceptions around whether or not they're going to be treated fairly, or whether or not the hospital has or the health system has a history of treating people of color more than likely, I'm not going to say better, but more than likely fairer treatment.
Absolutely. What you've raised, the proximity, if I heard, one of the words got a little muddled, but in terms of proximity, where hospitals are located in neighborhoods, I'll extend that a bit. We've also been hearing about, which is obviously related to it, transportation, right? Need for transportation. So both sides of it, the proximity might be convenience, but then also maybe there's preference to go somewhere else, but the what's involved in the transportation could certainly be a barrier. And this notion of feeling welcomed or unwelcomed, experiences in the past and how people have been treated, or maybe what they've heard, these issues have already been coming up. They have, and they're certainly, showing up as themes in the analysis of the focus groups that we've been analyzing already. So I very much appreciate you bringing that up, because if nothing else, once again, it's just more confirmation, from someone like yourself with your sort of initial reaction to what I'm presenting here, that is very much in line with some of the key issues that people have already been raising.
I was also going to just add just quickly that also bias and bias plays a role in, particularly I hear this anecdotally among African-American populations, gay and lesbian populations, particularly Black gay men, that they will choose a different location for care and treatment based on how they perceive bias or their privacy to be protected in in a particular healthcare institution. So they sometimes may choose to go downtown or to a different borough for treatment because they're concerned about their privacy and how that will play out in their local community if people are not, if they're not being treated fairly when they access the system.
Thank you. I see Eva Chan.
Yes, so I have a question about your data. Do you have the patient zip code, where they live? Because I thought that Dr. Franklin's point about, just proximity and the correlation of where people live and the hospital they go to would be quite high.
We do get zip code. This is going to be really interesting as we move into sort of the next phase of focus groups. When people fill out the screener, which I'll show you we can show you in a little bit. We can click on the link and show you what the screener, the data that are collected. But they first fill out a screener so we can see if they're eligible to participate. Like if they don't live in New York City, they're not eligible, right? If they're younger than 18. Otherwise, people are largely eligible. But we do collect information about their zip code as well as the neighborhood. It's sort of two geographic questions we ask that we look to align. The thing is that allows us to know how broadly, how diverse we are succeeding in recruiting people into the focus groups. But at the end of the day, when they participate in a focus group, we're organizing them by racial ethnic identity and by health insurance status, because those seem to be the two key factors, right, that are came out quantitatively on people's experiences. So it's quite likely that a focus group can have somebody from the Bronx and someone from Manhattan and someone from Brooklyn, all in the same focus group. Maybe what they have in common is that they have private health insurance or something like that. And so when we're having that conversation with them in the focus group, the analysis is at the level of the focus group. So we're not saying, okay, person X was from Astoria, Queens, based on the zip code, and person Y was
understand.
from.
But can you use the zip code data? Because I think, in Harlem, we looked into a lot of these healthcare accessibility questions and looking at, the zip code of the user of the facilities.
Well,
it's very telling.
And you're Eva, you're hitting on a really important point, which is why when I said this project is evolving, the exciting part we're at is that we just got approval to do a post-focus group survey. It's short, it's like 10 questions, but that's where anyone who participated in the focus group can do this quick 10-question survey. And that's where we're going to get that individual data. That's where we will have, their zip code, the name of the hospital or hospitals that they, tried to or received care from. If they feel that they're not able to receive care from a certain hospital, they can tell us which hospitals it is and why they may or may not go to hospitals. We are asking this information in the focus group and we're getting it at the group level, but now this post-focus group survey will exactly focus on what you just suggested. We're going to get it at the individual level as well. So we're excited about that because we can only now start rolling, we can start rolling that out as well. So, but yeah, please keep the questions coming. I'll just move along, but as questions occur, I'm happy to stop. Okay, so let me get my mouse back. Here we go. So where we are now and what we're looking toward, and again, everything can be modified. The beauty of a qualitative study is that it's really very flexible. And so we are in this first phase, and we have been, as I mentioned, recruiting people into focus groups in these two general categories of private insurance and public insurance, not Medicare, which is public, because Medicare is, we all know, very different from Medicaid. But and we're hoping to get to that, further down. But certainly, at the moment, we're running focus groups based on, people in terms of their racial ethnic identity and their health insurance status. And we've conducted about 13, I believe, so far. The goal is that it's a multi-year project through at least fiscal year 24. So, 1+ years more. And so we see ourselves moving into, subsequent phases, because the health department is really concerned with what they've been hearing anecdotally and what they saw quantitatively in terms of the distinction between people with private insurance and Medicaid. That's our main focus to start. But then the hope and plan is to move into or add on another phase, which would be folks who just don't have any source of health insurance. And for the most part, that's likely going to be, heavily skewed to non-US born individuals, maybe folks who are participating in NYC Care and maybe not. And because there's a potential for non-English speakers, we would, be looking to develop these materials in several languages in order to accommodate that. In the project that I did several years ago with Health in Hospitals, we actually conducted focus groups in 6 different languages, and we partnered with 7 or 8 different community-based organizations. We had resources available, to compensate them for their time. We co-moderated the focus groups. They took a look at the topic guides and made suggestions, for like wording and other issues. So it was very collaborative. And I would see, it happening pretty much in the same vein here as well. And then I had mentioned earlier, the hope is that there might also be, the ability in terms of funding and time to also include maybe especially vulnerable groups of New Yorkers. Thus far, the health department has talked about potentially formerly incarcerated individuals, unstably housed individuals. In that case, it will likely be more about their circumstances here, and whether or not there's health insurance, that might be less of the issue in terms of their experience with healthcare than the fact that they have these other challenges. And so again, through lots of conversation and collaboration, we would be interested in what people think about how to approach and incorporate vulnerable groups, and there may be others that you all and others would recommend. I see Serena Chandler has a question.
Hi, yeah, thank you so much. So on the vulnerable New Yorkers, they've got the health issues, but then they've got those other issues as well. Within this project, is there going to be a space for us to assist them with the other issues as well? Because we have to face that, when we're not housed properly, when we're addicted in some way, whatever our issue is that we're having, domestic violence, those things can create and exacerbate existing health issues. So within this, is there a plan to assist with the other stuff as well?
I think that's a really great question. It is, oftentimes the case where, at least in public health, we find ourselves doing a project because we want to understand more about what the issues are, and then realizing, this is an opportunity as well to intervene, right? And oftentimes the challenge for us is to not muddle the two, right? Like, we might be very skilled at collecting the data and analyzing it, but the ability to partner with organizations that have, probably in addition to that, the skills around engaging those, communities and special groups, and already are poised to deliver services, but maybe need additional resources to do so. I would say that our colleagues at the health department are pretty amazing to work with. Like, they are so open and wanting to, see what we think about how we can continue to expand and really, I guess, deepen this project. And at different times in the fiscal year, there are opportunities to request additional funds. Maybe some of you know this even better than we do, but at certain points when they look at their budgets and see that they are potentially underspent, they run the risk of losing funds at the end of the fiscal year, and it goes back to the state. So at different points, they will come to groups that they're collaborating with to say, is there anything that you would want to add on to or do differently or expand on your project, because they can go back and ask for additional funds. And so it seems like this would be an opportunity to partner with organizations that maybe serve some of these vulnerable groups. And, we could bring this research project to individuals that you all serve, and potentially also have obtained additional funds so that services can be provided, not by us, because that's not necessarily what we're doing here, but with our partners.
So maybe some of the funding could be used to create some type of a network of the people that could provide those services, and then maybe a exclusive referral system from healthcare to services.
I mean, I think if that's would seem to be a valuable resource, then I think I would defer to the on the ground service providers to do that. We we're looking, we're reaching out momentarily. This discussion would be a really good way to kick that off, but we've also been looking at other organizations that we'd like to partner with to help with recruitment in the focus groups, assuming that they agree that this is worthwhile. And we'll very likely have resources. We wouldn't do it otherwise, but we'll very likely have some resources that we can pass through to provide compensation for the time. And however our partners want to use those funds, certainly that's up to them. So so this sounds like it could be certainly one positive add-on to what we're doing. So so this is kind of what it looks like right now. We're in phase 1. We would like to be reaching out to organizations that are interested in this and provide some resources to maybe partner and to sort of ramp up the recruitment in this phase 1, component of the project here. We like I said, we've done about 13 focus groups. We'd like to do a bunch more and make sure that we have a substantial amount of input from New Yorkers within these categories, and then move on to the next. So that we could kind of talk about that maybe in the discussion after, but that's where we are right now. I wanted to share with you these 2 slides will just give you a sense of the kinds of questions and conversations that we're having in these focus groups. I know we said it's about access to healthcare and health equity, but just to sort of dive a little more deeply into it, and specifically so you can see, you know, if you want to read through, we kind of abbreviated the questions. They're a bit more conversational, but you can see from just the abbreviated text here, the gist, and I'll just sort of review with you all the main domains, maybe while you take a peek at the questions themselves. So we pretty much start off with asking about what factors people take into account when they're thinking about, you know, a facility, a hospital that they might go to. You know, I refer back to Dr. Franklin's comments earlier on. You know, maybe it's because it's in the neighborhood. Maybe it's because it's convenient. I don't have to take transportation, or maybe they're traveling because they don't feel welcome at a place that's nearby, and they are going out of their way because they feel more welcome somewhere else. Eva?
I know your approach is very much focused on having a focus group, but does the hospital system provide data of their clients? Because I'm just thinking, if you get data of the zip code of their clients, then I think that should be a pretty good, give you an indication of the driver.
Yeah, so
you know, nearby people who are using the facility.
I would say that that would be a perfect scenario to go back to the Sparks database that I described that the health department had looked at. There's a lot of data there, and patient characteristics. You know, if I were a betting person, I would say that they most certainly would have the zip code of the, you know, their patient's residential address and zip code, and then also know which hospital they were discharged from, right? So I think, Eva, the type of analysis you're suggesting would be probably very possible with Sparks data that already is, you know, is available every year. And I think it's a great point. I mean, we're presenting to the health department tomorrow on just an interim report on where things currently stand with this project. And as I mentioned, they're really very interested in feedback that we get, not just in the focus groups, but from our outreach with folks like you and, you know, other stakeholders. So, you know, I would love to go back to them and ask them if they've thought about looking at the concordance or discordance, right, between zip code and neighborhood, where people who are discharged from hospitals, you know, where they live, in relation to the hospital that they sought care from. Just keeping in mind that these are discharge, you know, data. But I'm, you know, I'd be curious to see if they considered doing that analysis, or if maybe if they've already done it as part of the analysis that I just briefly, you know, I had briefly summarized at the beginning.
Because I think, I mean, location, just proximity to travel, right, to healthcare, especially in lower income neighborhood, it's very important aspect. They don't want to take time off work.
Yeah.
And so I almost wonder if you want to just conduct that analysis and kind of filter out, okay, we identified the key drivers and what are other drivers that are, you know, driving people to not go to their next door hospital.
Yeah, no, I'm definitely going to bring this back to them. They're in a much better position. They already have the Sparks data, like to access the Sparks data from the state, like any administrative data set, you know, you have to go through a few hoops to access the data and then run secondary analysis. And they have already been doing that, but it's a great question whether they have looked at zip code of residence versus zip code of hospital to try to at least quantitative look at, you know, where people are going to relative to where they live.
Yeah, because I mean, I just worry if you recruit focus group, it's naturally quite a biased process, right? Like I can help you recruit certain people, but then it would just be, you know, people in my universe. And I just worry, you know, what kind of conclusion can be drawn from
Excellent point. And in fact, that's why this first batch of focus groups we've done have been just through our own outreach and recruitment, which is very broad-based, and it hasn't been in collaboration, in close collaboration or partnership with any one entity, because we do want to cast a wide net across the city, and we're trying to minimize as much as possible bias that might be associated with just bringing in individuals who are connected to specific organizations. That said, if we reach out to many organizations, like let's say even everybody, on this call right now, and through all of your respective outlets, you share our flyer, let's say, then just by virtue of the broad-based process of that, we would minimize the bias if it were just a few select organizations, if that makes sense. But those are two separate points, both very valid. I'm really excited to just even ask the question on that, the zip code piece, the location piece of our health department colleagues, because again, they're the ones who really have readily available those data. So thank you. I see
Dr.
Sean
Romero,
Hill has a question.
Yeah, I was
Oh.
just going to say you have more hands up.
Hello, thank you. Thank you. One of the things that strikes me, and I'd like to follow up with what Dr. Franklin was asking earlier on about a bias treatment, the treatment bias in a particular healthcare environment. Is there a database, or is there data from various private and public hospitals about cases that have been brought, either legal cases or protests for treatment bias? And is that something that you're incorporating into this? And then my second question revolves around the issue of the lack of choice in terms of which hospital or facility you go to. And that is, of course, if you require ambulance treatment or care. And I don't know, this is not my world, but I assume that there are geographic zones. So if you call and get picked up here, you get taken there. And if you get picked up here, you get taken there. So I would like to know how that may impact the numbers that you're seeing about where somebody may end up, even if that may not be their preferred hospital because they've had a bad experience there in the past or whatever. So just want to follow up with Dr. Franklin's question about bias treatment and the mapping of that, and also the complexity of being delivered by an ambulance.
Great, thank you for that. So, to my knowledge, and it may very well be imperfect, I'm not aware of any single database or source of information on any complaints, right, or cases that may have been brought against hospitals or healthcare facilities. It's possible that it exists, but that has not come up to date. And at the health department, they've shared with us a lot of, I guess, what they're calling anecdotal information of these kinds of concerns, right? People feeling that they've been or have been treated in a biased way. The example that you've given about complaints about ambulances not taking them to where they want to go. This is, I guess, the way they've shared it with us might be referred as hearsay because it's sort of through their channels. And some of the staff who are actually clinicians in H&H hospitals and other staff. But nonetheless, they feel like it's real and they've wanted us to probe on that. And in the next slide, I'll show you how we're probing on it. But I'm not
right,
aware of a central.
Sorry, because I would suggest that there are lawsuits out there where people have been so egregiously treated that they have actually filed a lawsuit against a hospital. So I think that's one source that I would recommend you look into, because those are obviously very egregious. The second is just a standard complaint. When people are discharged, they're routinely given, how was your time with us? How did you, and surely there are parts within the hospital system that record every time someone complains about biased treatment by a physician, by a provider, whatever. And I think, those, in addition to the anecdotal examples that you talked about, would be very important to get. Obviously, only certain, people would require a certain amount of social capital to feel empowered to bring a lawsuit on against, or it has to be extremely egregious. But I think those might be avenues to explore as well.
Yeah, and I'm jotting it down. I'm sure Samantha is. I will say that the drop down question, that lists all of the hospitals within the 5 boroughs is quite extensive. And my feeling would be that it would be probably individual requests of each of those hospitals to be able to access data on complaints that have been filed. I would also think that some of this might be pushed off as like having to submit a FOIL request, right? Freedom of information. So it's not impossible, but my expectation is that it would probably be sort of a, one by one. I'm not aware, and we can check this out to see if that's correct or not, but I'm not aware that there would be a single repository for all of this information, given just, you got private hospitals in the mix and public hospitals in the mix. And what we've learned in previous work with just H&H is that they're part of the larger public hospital system, but at the same time, they also work fairly or function fairly independently as well. I just, while I really appreciate the recommendation, because it seems like we would hit on the head concerns we have about differential treatment, one setting versus another, it probably would also be a very extensive project in and of itself. But I love this idea and would certainly look into, just asking those basic questions. Is there a central repository to begin with? So thank you for that.
I was going to add, Sean was asking a question about mapping, geographic mapping, what was one of his secondary questions. But I think that there perhaps is a comparator, maybe a secondary data set that you can look at, looking at the indigent care pool. And there's certainly federal numbers on how money is spent and where money is spent based on private and public hospitals. And so that might be a secondary way to collect data on how people, what factors affect individuals' healthcare experience. Because you mentioned about in here the question, how have income and cultural backgrounds and race and ethnicity impact your experience? And a question around how does income and your quality of life, or the level of income that you make, how does that affect how you impact the healthcare system? And certainly here in the city, public hospitals and the private hospitals are in a constant argument around the indigent care pool, because it's a fair share formula, and certainly the public hospitals believe that they see more patients that meet the criteria of what is indigent care. And then just on the last note, focus groups are part of a qualitative methodology, and it's not biased, but there's a limitation in replicating that. So I didn't want to leave that out there as that it's just a bias. There are limitations to focus groups.
For sure, and thank you for all of that. I think this is like a building for us really beneficial. Sort of like we're building a list of additional research questions that are very related to this overall topic, but that likely can be asked by being able to access additional data, right? Different sources of data, which I'm, really intrigued by and keeping track of. In terms of just that, the one thought about trying to access data on resources provided to different hospitals and how that may differ, we'd want the, resources provided to different hospitals, but at the same time relative to, like, I guess, some metric of population served, like, I don't know, number of patients served in a year or hospital beds, et cetera, some metrics so that we could, make sure that comparisons are, they're reasonable comparisons. But it would be interesting if and to what extent those data would be available from private hospitals, right, which are getting have other avenues or sources of resources. But again, it's, I think, really useful food for thought. I see George Dawson.
Yes, hi, good afternoon. Interesting
Hi there.
discussion. And so I guess my first comment is that a lot of the questions I see here have been answered. You just Google the literature, Black experience with healthcare accessibility or manpower issues. I mean, they've been answered. I think the emphasis should be rather than on what can hospitals do to be more welcoming. And that's where the rubber meets the road. And but I mean, it's just a ton of literature on the preferences for Black patients, for Black doctors, or culturally similar doctors, not necessarily Black. Some people are good-hearted and can take care of, as a retired physician, I'm speaking from that experience, can take care of that. But we know that there are issues why people don't want to go certain places. I mean, that's already been determined. The question is, if they don't want to go, how can we make them comfortable where they're at and where they do want to go, be it Harlem Hospital or Metropolitan or wherever, so I think upper middle income Blacks may not have that problem because, again, it could be culturally related. And so the question is, how do we make those hospitals that some folks go to more up to date in the care they provide? I don't think somebody should have to go to New York Hospital for a particular procedure where they can get it in Harlem or whatever. You know what I mean? I just don't know.
Yes.
This is questions that have already been asked and answered.
Right. Well,
throughout the literature for time.
so
And
what?
the question is solution.
Right. And so I'm gonna click. So since I've had the screen up, I'll just click to the next, the other half of the topic guide, if you will. So folks, while we're chatting, folks can be looking at the other questions as well. Since it's kind of got these 5 major domains. But going back to, Mr. Dawson's point, yes, but this is what I would say. A lot of the questions here have been informed by the fact that we know from the literature from other settings, other population groups and other time periods, that there are these sort of like usual suspects, if you will, about the barriers to healthcare, the factors that matter more or less to people, and the nature of some of the experiences they've had. So, we're benefiting to a large extent from previous research, previous literature, and, just knowledge about the experience of accessing healthcare. At the same time, the New York City Department of Health is really interested in having the findings from research like this inform very specific policy and programmatic recommendations that they make in New York City. And so being able to work from data collected specifically from New Yorkers in this moment is really, if not important, but necessary to them. Just the validity of saying, this list of 10 recommendations that we're making for, hospitals in New York City or in specific contexts are coming directly from the words out of people's mouths, right, who live in New York City, that's, you know, where, so there may be overlap with, you know, other maybe large urban settings or, you know, within the last few years, but the specificity of New Yorkers now, like in this moment, so that they can make concrete recommendations is really, you know, what's driving this project or the way it is right now. What I would say the other really important part of it that, you know, I haven't probably highlighted enough is that the way we can best, you know, make the best and strongest case for groups that are not getting equitable healthcare access, that are having negative or detrimental health experiences, is to have a comparison group so that it can't be dismissed that, oh, well, you know, the entire hospital system or healthcare system in New York City is broken. If without the ability to say, well, look, these groups are, you know, have a laundry list of negative experiences compared to this group, that is what gets to, you know, the experience differential access to care and what we're calling segregated healthcare. At least those quantitative data very, very much demonstrate segregated healthcare. And that is what has the health department really quite motivated around this. So we're not just, you know, involving individuals who have, you know, presumably less access to healthcare or negative experiences. We are also including people with private health insurance, people who identify as white and possibly, you know, are on the higher end of the income spectrum, you know, a wide range, so that we can say, look, the focus groups we did with individuals, you know, with these characteristics pointed to a lot more barriers or negative health experiences compared to the focus groups that we did with individuals with these healthcare experiences. So that is, you know, a part of this. We're not just focusing on the quote unquote vulnerable or groups that we're presuming have less or inferior access to healthcare. We're trying to cover a broad swath so we can really shine a light on where those differences are. I hope that helps a bit. I'm not sure, I wonder if, because I'm not sure whose hands were raised first. I don't know if Priya.
We have Eva and then Serena.
Thank you. So, I mean, looking at this list of questions, one thing I have is I'm not sure if I see a question of whether people are able to find the service that they need from the hospital near, or whether, you know, the kind of service they need is available. The reason why I'm asking, it's almost, I feel like from my experience, different hospitals provide different services. And for me specifically, I've been looking a lot. You mean this one? Okay, so I've been looking a lot at, you know, availability of drug treatment, kind of addiction treatment services. And so what we see is when the neighborhood real estate prices go up, the hospitals start to shut down some of the services that are not as profitable. So that seemed to be a very big driver of whether addiction treatment are available in certain area. And we have seen, you know, historical data of, you know, say Mount Sinai in Midtown and Union Square area, basically shutting down the whole department of addiction services and just moving it to Harlem. And it's largely profit driven. So do you have, I mean, do you control for availability of services in this study? I mean, I think that's also a big reason why you find people without insurance end up going to places like Harlem for treatment because they simply, the treatment they need is simply not available in higher income area.
Right. So, yeah, I pointed to this one. And again, we truncated the questions. They're just bulleted. So there's more. We have probes that are not in here. This was like for readability for you to get the general thrust. But their specific healthcare experiences domain absolutely gets at what you're talking about, Eva, with one caveat. So what I will say is that, a sense of how often they've been access to healthcare when they needed it and what that looked like, what that experience was. And then, we probe on, multiple issues like you just raised. And then we ask this question, if you could go to any New York City hospital, where would you go to get a sense of, is it, a hospital that's offering specific services that they need? Is it, because it has a great reputation? Is it, because it's right around the corner and they're perfectly happy with it, so this domain is much more than just these two summary bullets, but it does get at the thrust of what you were just talking about. The one caveat I would say is that no one to date, to my recollection, has talked about, for example, services like you mentioned, right? Like substance abuse or disorder services. And I'm wondering if, for one thing, that might be a really good group to include among these potential vulnerable groups, right? That we mentioned earlier. I would really think that might be a really good fit. And at the same time, in these other focus groups we've been doing, there's certainly stigma around certain things, and that would be one of them. And so it's not to say that we haven't had individuals who may have a substance use disorder, but didn't feel comfortable, right? But if we do focus groups with specific vulnerable groups, and that ends up being, one of the groups, that's where we would get probably very rich information. So I'm feeling like you already, kind of gave us a way to address that and flesh out more that vulnerable group category.
Yeah, I think focus group is great in terms of, once we hone into a specific group that didn't feel comfortable in accessing nearby healthcare, then having a specific group to kind of flesh out more of the driver, what their concerns are, then we can get to kind of constructive solution faster. On the chat, I did post to you the data that exists, kind of showing inequity in healthcare accessibility.
That is great. Thank you. And I see that Greg also shared with us. That's wonderful. And I'm just assuming that Samantha's capturing that. So Deborah, who did you say was next?
Miss Serena?
Okay.
Yeah, hi. So I think I'm going to echo Eva just to say that our zip codes do dictate the level and quality of services that we receive. And that should be something that's broadly explored. But I also want to say about the hospitals, I'm not quite sure if I'm going to use the right term, but aren't there still ombudsmen in the hospitals and social workers in the hospitals to take the complaints that people are making about the quality of care or the lack of care that they are receiving in the hospitals? And the point of when you call 911 and get the ambulance, they're not going to take you where you're asking them to go. They're going to drop you off at the closest hospital to you. So all of that, again, factors into our zip code dictates the level of care that we receive. And where is that at within this situation?
Yeah, well, so when we ask, I think just from this conversation, we're going to go back and I'm going in the wrong direction. Sorry, let me make sure I go back. I think just from this conversation, we're going to go back and look more closely at the questions that are in this first domain here about the choice of facility and finding care. We do have probes where we ask about proximity to where you live, transportation required or not required. I know, and yes, and proximity and transportation have come up, but it's certainly worth, based on the emphasis from this conversation, making sure that we're getting at it as explicitly as we can. And I am very intrigued about whether the health department already has, or if they can go forward and do a zip code analysis. It really should be very straightforward to look at zip code of residence and zip code of hospital facility that care was received from. Now, they're highly unlikely going to be exactly the same, but we know that there are clusters, right? Like zip codes, it could be an adjacent zip code or a nearby zip code. So it may take some, as was mentioned, geographic mapping, maybe some GIS analysis to sort of determine proximity, because it won't necessarily be the same zip code. But I think, the message, has been made strong and clear about the possibility that that's a big driver. And I love your recommendation about an ombudsperson, going back to, if I captured it correctly in my notes here, I know Eva brought it up, and then was it Sean brought up the question, the issue of bias complaints and all. Even if it's a sort of manual, if you will, hospital by hospital look, it's certainly worthwhile to see, do they post information on their websites? Is there an office of ombudsperson? And would an inquiry to that office about, being able to see the latest sort of report on complaints or feedback, is that even publicly available or easily available? Right. So I think, these are all very straightforward steps we can take to sort of provide a deeper context, to this project. So thank you. So the last thing on this, I just want to say again, these 5 are these big domains of what we've been asking about. We continuously are revising, and so we'll likely after this meeting go back and do a little more tweaking. But this specific scenarios down here at the bottom is the most recent addition, and it has come, like I mentioned, from our meetings with the health department. They have provided us with some of this anecdotal information that has come back to them by colleagues in the health department and clinicians who are actually at different hospitals in the city. And so, for example, people feeling that they are treated by a healthcare provider of a lower level of experience and credentials, right? They get medical students and residents and not an attending physician. Or, they get a nurse, not to disparage nurses, but they don't get the doctor, they get the nurse. Also a scenario of being sort of redirected to different healthcare providers, who maybe accept, health insurance, but not a different kind of health insurance. They've heard about in hospitals, actual physical segregation by insurance status. So if you have public health insurance, for example, you have to go to a specific wing or a different floor for care than, people who have private health insurance. And then also scenarios of maybe receiving emergency care at a hospital because that's where you were taken, but the follow-up care that you're recommended to get is not at that hospital. It's at a different hospital or with a different medical group. I believe there was actually, maybe Samantha can correct me if I'm wrong in the chat, but we have 5 scenarios, and I don't know if it got cut off on this slide, but we actually have a scenario about that ambulance situation of having ever been taken in an ambulance and asked to go to a specific hospital, but not being taken there. So that's relatively new, and we are running the focus group folks through these different scenarios to see if it resonates with their experiences and what they can tell us, specifically about that. I think, Eva, do you have another question?
Yeah, so it's real quick. So I was actually going to comment on what you said about how you might go back and look at the zip code data. I think that for most analysis that's done, I would highly recommend segmenting the results by service required. So I suspect that, whatever analysis you do, if you look at, patients who are treated for or heart disease or diabetes or addiction or mental health, if you segment individual group, you might get pretty different results. And then, yeah, so in terms of quantitative analysis, I would recommend segmenting the data to see if there's systematic difference. The other thing is, I just want to echo what you said about ambulance. We heard multiple times that the ambulance sort of self-select. If they suspect this patient cannot afford the healthcare, they would send them to, say, the Metropolitan Hospital, just by kind of how the patient looked, regardless of where the patient was picked up.
Yeah, and I've been wanting to get my hands on if there's a specific policy or city regulation around this, but our understanding is that the ambulance drivers are supposed to take individuals to the hospital they want to go to, unless they believe it is, a high level, I may not be saying this properly, but a high level emergency, right, where they have to go to the closest. But we've been trying to get, the specifics around that. So anyway, we do have a scenario on that, so I just want to make sure, and I may have cut it off of this slide. So I think there's just a couple more, and then I'd love for this conversation, to just keep the conversation and your thoughts coming. I just want to give you a quick snapshot of what we have employed to date in terms of like outreach, to sort of let different entities across the city know that this project is happening. We have, shared the flyer with some, different community-based organizations, but certainly not all, and that's still, an ongoing process. The Department of Health has, grantees that they provide resources to, and they've shared this information with their grantees. We have been in the process of presenting at community boards across the 5 boroughs. I have presented to all of them, and I don't know, again, maybe Samantha can put a number in the chat or something, but it feels like it's been more than 20 at this point. And so, we're going to continue until we present at all 59 community boards, and we're asking them to get the word out. So this goes back to, this concern about bias, to the extent that we can blanket and reach out through a wide range of modalities that would mitigate, us being in a position where, only people, who receive services from one organization were mostly involved, or one borough specifically, or, we're really doing this broad-based. We've been in touch with all the borough president's offices in addition to the community boards, and the community boards were presenting at their the committees on health and human services, as well as the general board meetings. So again, we're probably going to have made over 100 presentations, but we're prioritizing the health and human services committees because they're the ones who have the most interest in this. It was really through some of these presentations that it was recommended to us that we reach out to the parent coordinators, the school parent coordinators through the health department, and there are also wellness councils through the DOE. So it's not the easiest thing to access these lists of these contact individuals, but we've been chipping away at that. We have 3 public library systems in the city. And they don't work together. So we've been, reaching out to each of the 3 public library systems and have had meetings with like directors of community outreach and, to get the word out that way. Obviously our own, school, this is one of them certainly, but social media and other venues, and then in-person events, which we really want to continue to do. Any in-person events that we hear about, we would love to be able to do tabling or distribute flyers. We would come with tablets so individuals can do the screener survey right on the site, on the spot if they want to. You'll see that our flyer has a link, but also a QR code, and people, if they have a smartphone, can scan it and do the screener themselves. But in person, we would bring a couple of tablets with us. And let's see, and the point is that we don't think we're ever going to have a complete list, right? Such a thing doesn't exist. And so we're constantly asking what other ideas might any organizations or individuals have for how else we might be able to reach out. So anything along those lines in the chat or or as part of the conversation would be great. Eva?
Yeah, so related to this, one reason why I joined the meeting today is to advocate for the Asian seniors in Harlem. So I just want to describe to you the issue. I'm not really sure what is the solution. So basically, the southern part of East Harlem, 11% of the population are Asians, and they're mostly seniors who don't speak English at all. So what we found is right now there are no healthcare providers that have the language skills to support them. So even at the height of pandemic, when the subway was dangerous, when people are afraid to go out, the seniors have to travel to Chinatown for healthcare. And especially, during days when it's really cold, it's truly a challenge. So I'm hoping that you're welcome to, work with me to reach out to these seniors, but I think the data speak for itself. There's not much more to it, right? They simply can't go to the doctor and can't describe their issue.
Yeah.
So they need healthcare provider who speak the language. And I'm wondering if there needs to be some sort of guideline if certain district has more than certain percent of population who cannot speak English, then the hospital needs to supply healthcare providers who can speak the language.
Right. Well, and you see, being able to hold a focus group and have information like that come out in the focus group and be part of that whole collection of data we have and we're reporting would be ideal. We've heard just from the community boards in Staten Island that we've presented to. Staten Island doesn't have a public hospital. There's no H&H in Staten Island. And we haven't been able yet. No one from Staten Island has participated in our focus groups. We have over 50 people who participated in these focus groups and no one from Staten Island. Now, part of that may be, that our outreach needs to be better, even though we are including Staten Island. But what I said was, this is all the more reason why one of the community boards in Staten Island might be motivated to help, recruit or spread the word so that people participate in focus groups, so that can be captured in a focus group. So what you're saying is really quite profound, Eva, about that community and the ability to conduct a focus group and capture that and include that, in the data would be amazing. So yeah, I mean, we're poised to follow up, with anyone on this call who would like that. I love to, continue that conversation and see what we can do. So just to give you a quick, I know this is not a good
Diana,
image.
you have one more question up.
Oh, I'm sorry.
Sorry.
Yeah, Kadeem, sorry.
Hi, yeah, no, just to come back to Eva's point. So for the focus group that is going to be run, what particular structures are in place? I know that you in the slides you showed us that you're going to be having a section for non-English speakers. But what particular structures are in place to facilitate ease of access and ease of communication for those populations?
Yeah, well, so when we move into focus groups that involve non-English speakers, obviously we're going to have worked with community-based organizations that serve these populations. And in the past, with my previous H&H project, we had all the materials translated forward, back, and then forward again translated. We co-moderated, but the moderation was led by a member of the community. I mean, all the materials were translated, but the focus group itself was led in that language by a member of the organization who had a relationship with the community. And then we collaborated on analysis of the data itself. In terms of transportation, we've always worked with the community-based organization in terms of what they think is the best way to accommodate that, whether Metro cards would assist with people being able to participate, or other resources that would be helpful. So we don't, with a more community-based approach, we don't necessarily decide these things up front. We're waiting until we establish some of these partnerships, or at least have preliminary conversations with different organizations, and then largely, follow their lead on what they think would be most useful to those community members.
Thank you. That does clarify things. And so just with regards to the specific intersection that Eva mentioned, in terms of non-English speaking and being an older adult, or even, for example, being an older adult and having disabilities. So are there also specific thoughts with regards to those intersections? Because I know that you're looking at specific categories. For those categories that overlap, what's the strategy, to take that into consideration?
Yeah. Well, the senior piece of it, one question would be, are they receiving Medicare, or are they uninsured, right? Depending on what their status is in this country, it's quite possible that they don't have any health insurance at all. But as I mentioned at the outset, folks who are sort of in that Medicare group, that's probably, a factor to a certain extent, an equalizing factor, because, Medicare has a certain common thread in terms of the types of health care that people have access to. And so we would determine whether we would do groups that are stratified, by that are all Medicare, but then the stratification might be maybe different cultural backgrounds, particularly if they're non-English speaking, right? We would have to do it linguistically so that, it makes sense in the implementation of a focus group, that it's being conducted in the same language. But, big driving forces in this, at least the preliminary data, have been around the nature of health insurance that people do or don't have, and some, characteristic that might lead to whether they get equitable healthcare or not. And that has tended to be more racial ethnic identity. I would argue also, when we get into the non-US born, cultural background and, other nationalities. So it's likely that we would do stratification along those lines. But the minute we enter into the non-English speaking, that is going to have to be a stratifying factor, just for the purpose of being able to conduct focus groups in a language that everyone in that group speaks and understands.
So Diana, we have 2 minutes left for this. conversation, but I do want to just give you one piece that got dropped as a note,
Mhm.
which was the impact of COVID on the hospital workforce, and that even though hospitals may have particular services that they offer, they, in a lot of cases, are struggling to get the actual professionals to fill those roles. So that might be another factor to look at, is the vacancy rate. And then there was another note that said, talk to the nurses, they know everything that's going on. So
Yeah.
those are the two tidbits that got dropped. And I see that Dr. Franklin has his hand raised before you close.
Okay,
Right.
that,
Thank you, Ms. Levine. I just wanted to add quickly that I've served on the Community Advisory Board for Harlem Hospital, and we have a patient advocacy group within that board. And so I was wanting to recommend to reach out to all of the H&H hospitals, because they do have the community advisory boards, and specifically here in Harlem with Metropolitan Harlem Hospital, we all have, in Sydenham, have community advisory boards. And so I'd encourage you to reach out to those groups and their patient advocacy representatives that serve on our board. Also, I'm not sure if you guys have been to the community board here in Harlem, where I serve on Health and Human Services. You may have presented in the fall, but we certainly welcome you to present in at our community board meeting.
that would be great. We've reached out to all of them, and I have to honestly tell you, after presenting at probably more than 20, I don't remember off the top of my head which ones we have and which ones we're still trying to schedule, but that's wonderful, because that is ongoing. I'm presenting, I think, at one next week, and we continue to schedule. So I thank you for that encouragement, and also the recommendation on the community advisory boards at H&H. I love, Deborah, also the other comments you mentioned. It does remind me that another piece of this is intended, and the timing of when it happens has been unclear, and I think we wanted to make sure we had enough insights from the focus groups to then have an informed conversation going forward. But the health department did like the idea of maybe us doing like key informant interviews, and speaking with nurses who know what's going on, and maybe other administrators at hospitals, given the impact of COVID, makes a lot of sense. And those would fall into that category, key informant interviews, to try to, if not validate, provide complementary information relative to the experiences that people are having, in the hospitals themselves. So I know we're 1 minute past the half hour. I'm just showing you here a screenshot of the flyer, but I'm asking Samantha, if she hasn't already done so, to drop the the URL, the link here to the screener. This is what the flyer looks like, and we have the URL. People can click on that or scan the QR code, and we can certainly, through Deborah's team, share the flyer with you all and follow up with conversations if you want to talk more about it, and think about if you think this would be worthwhile to share with your communities. That would be, we would love that. And then I think this was pretty much it. The link again here. We've been talking, throughout this presentation. So I'm happy to stay on. I understand people, probably just gave up their lunch for this, but I'm here, and this is our contact information. And I just really appreciate how you all just, leaned in. These questions and suggestions were both, really probing and very useful and concrete. And I think it's given us a lot of next steps to follow through. And I just encourage you to, if you didn't already, let us know in the chat if you want to continue the conversation and see if this is something that you'd like to collaborate on. That would be great. Otherwise, we're happy to follow up as well. Thank you so much.
Thank you, Dr. Romero. Thank you, community, for always stepping into the space and keeping us on the straight and narrow. You have a commitment from our dean, Dr. Ayman El-Mohandes, to always center community in the work that we do. So Your input in this conversation is always critical. As always, we'll just put up a quick survey at the end. This recording, along with the presentation and the follow-up, will be sent out within the next week. Please, if you think about something, if something resonates with you later, if you want to help get the word out about these focus groups and help guide the process, please reach out to us. We also promise, and I'm putting Dr. Romero on the spot here to come back as the focus groups and this work continues to report back to you. We don't just come and ask for the information. We also want to be a resource to share the information. And Dr. Franklin, we will take you up on that offer for Community Board 10's Health and Human Services. And I will reach out to Shatik to make sure that that happens. And Community Board 9, 11, I'm shouting out to you to ask you for your assistance to make this happen also. Once again, thank you very much. And if there are folks in the other boroughs that can help us have this larger conversation, please, please, please reach out to us. No conversation is too difficult for us to sit and have. So once again, thank you all for your time, your energy, your talents, but most of all, thank you for what you do for our community and being that voice for those who feel they don't have one. Stay safe, be well, and thank you very much.